And what I propose doing is going through a wonderful deck that Ria Racho and Michaela Jackson put together in the past. And then we're going to go through the MMWR document briefly, which you all should have on file. If not, the PDF can be downloaded from the website or through a link through our team. But this event and these two changes with the vaccine guidelines and now screening guidelines has just been earth-shaking for the hepatitis B world. I'm saying world because when this is happening in the US, it's very likely to be replicated in some form throughout the world. As you know, AASLD is rewriting their guidelines now. WHO is rewriting their guidelines. EASL has guidelines that they haven't published yet. So I think they're sitting on them pending some of these exciting changes that are going on. And let's walk through some really important information. I think this deck is going to be widely shareable, and we're working on an update to the deck with the data from the document. So I'm going to walk through what's in here quickly, just to remind people that there are 2 people dying every minute of hepatitis B. And I really want to also share out with you via Catherine what's called the 5-line guideline, or the 5x5x5 rules. And love to get your feedback. And you can send an email directly to me with your comments. I'm crowdsourcing this super simple way to try to get the international organizations to make things very simple. With all the guidelines we've had out in the last 20 years, there's been no inflection on the death rate from hepatitis B, and the guidelines clearly aren't delivering us on a path to hepatitis B elimination. The guidelines have also ignored basically stigma, quality of life, extrahepatic manifestations, other types of cancers related to hepatitis B, that this is an infectious disease other than mother-to-child transmission, which of course is very important. And within the new MMWR and the CDC release, they talk in a very strong way about how taking a risk history is stigmatizing and why that should be de-emphasized. You still have to think about risks because of repeat testing for hepatitis B in certain individuals, but everybody should have a one-time test without having to go into some detail about their risk history. You all know about other epi here. This 2.4 was really nice because they said in MMWR up to 2.4 million. That was the paper that Robert Wong and all my wonderful collaborators put together in hepatology of 2021. So up to 2.4 really is the number you need to be thinking about. I think there's some background noise, but very low testing rate, very low awareness, and even much lower linkage to treatment. And there's a lot of issues in that linkage to treatment. In the 5-line guideline, which will be circulated, we took cost considerations out of the equation, because once you bring in cost, you end up basically just arguing with yourself about what the right thing to do is. We're definitely pushing what the correct structure should be for managing hepatitis B. And super simple, you test everybody, you vaccinate everybody who is triple panel negative. And if people have surface antigen, they get a DNA. If they're DNA positive, they get linked to treatment. We've done this for HIV. We've done this for hepatitis C. Why aren't we doing it for hepatitis B? B has a very high infection rate and mortality rate. So we had some universal vaccine rules for infants since 1991, but it took this catch up in 2022 to have a effective vaccine policy. And of course, as you all realize, once you're over 59, you're not an adult anymore. So I'm happy in that non-adult group right now. But yes, we are going up to 59 to vaccinate everybody. And over 59, you have to go back and take a risk history. It was very interesting on the vaccine call right before the vaccine was released. This is a panel that was almost all pediatric people. And they said, well, if you're over 59 and you get hepatitis B, you're going to die from something else. And I thought that was phenomenally insensitive. And I really think it should be vaccinate all adults if there's a reasonable lifespan for those individuals. Back to vaccines, there's a really nice list here of our vaccines that are out. You've had Prehebrio that just was approved by the FDA, and Heplisab has been out for about 8 years. So you've got some great vaccines that are available. I don't know if this video is going to work, but I'm just going to try to run it for a second. If it doesn't, we'll just skip through this. This number is now 262 million people from our recent estimates from the Polaris group. And again, most people don't know that they have it because we don't have an infection. I don't agree with this statement. I think many people have symptoms, and there's also issues of symptoms related to stigma. And of course, you've got these issues about liver disease, but this is an infectious disease. So this is super important. I'm going to basically pause this here and go on to the next slide because there's a very, very important story that's built into here that you all could listen to via the link. Let's see if I can get to the slide. Yeah, there we go. Let's see if I can go forward. There we go. So we have the universal vaccine information. I'm going to move on quickly and talk more about testing today, of course. And there's very important issues here about vaccine access, health department support, distribution barriers that are all part of this as well. Some really important issues here about health dependency and partnerships that are here. There's a way for health departments to purchase vaccines, but most vaccines, in my experience, are given in a clinic setting. And this does come back to testing because the testing recommendations are for the triple panel. And this was found to be cost effective by Malika Toy and Sam So's information, and how really that document helped really move this testing algorithm forward with all three tests. As you know, in immigrant populations, core antibody is found up to 60% of individuals. In the general US population, you're going to see core antibody in about 6%. But if people have core antibody, you don't vaccinate, you don't boost. Those people have low-level hepatitis B in their body if they're surface antigen negative. They need to be educated about risk of reactivation as an important issue, maybe looking for occult hepatitis B, but they don't need vaccine. So the testing from MMWR and the vaccine guidelines are now, in my opinion, nicely integrated. Getting to the MMWR 2023, they did this very nice modeling about cost savings and how many lives we will save, decompensated cirrhosis, cancer, transplant, and death. And this modeling really helped, as it was very, very well performed, very well studied to get the CDC to move on this next recommendation. So a little bit more on vaccine, working towards health equity, super important. Little description about age issues. We're really trying to bring down these financials and systematic barriers. I'll call them systemic barriers. And of course, working through the USPSTF will be a next key step. Although I personally have ordered a lot of vaccine or asked primary cares to get vaccine after doing standard screening, and I haven't had any pushback where patients have a significant out-of-pocket cost, but there are areas where it is an issue. We need to harmonize this across the country. You all are part of patient provider education. You are working with advocacy organizations because you're here today. And please work with your clinics, your hospitals, and health departments to help make this work. There's a lot of implementation strategies that are available and ability to spread awareness. I'm moving through this since we're going to be sharing this slide deck out, and here are really nice listed resources. And again, up to 2.4 million people have hepatitis B. So that number from the paper with Robert Wong and I was in a prominent position. Lots of resources, and emphasizing hepatitis B can be more dangerous than hepatitis C, but you have to worry about co-infection, of course. And we have a strong statement in this 5-line guideline about testing every hepatitis B patient for Delta antibody, just to make things also quite simple. We really need to simplify this process. We have great ways of tracking vaccine. We have great ways of tracking testing. And Catherine, on that short note, I'm going to switch to a view of the MMWR and PDF. So I stop sharing. Go back to this. Let's see if I can get back to share again. And I'll stop just for a moment to see if any questions have come in. Let's see, share screen.
I will note as you're doing that, Dr. Gish, that I also put a white paper that the foundation put together that talks about implementation strategies and recommendations by a network of experts as well. So definitely check that out if you're interested in learning more, thinking about in different ways of strategies towards implementation of both vaccination and screening.
There's going to be a lot of statements coming out, and we continue to work towards a dialogue with the administration as they move this hepatitis C, what I call a moonshot program forward, to make sure hepatitis B testing at a minimum is included in that. We don't want to confuse or detract from the main hepatitis C message, since it's now a short-term treatment, curable. Hepatitis B, we still have our challenges, but we can reduce liver cancer risk by at least 70% by treating all individuals who are DNA positive. And the cancer risk is statistically increased at any level of HBV DNA that you can measure. So we have the data today to implement these very broad-based, simple guidelines about treatment that parallel HCV and HIV. We have equivalent data, in my opinion, about hepatitis B impact on life and survival and morbidity and mortality that we had on HIV and hepatitis C that moved to test all, treat all. HIV is not curable. These people are on long-term treatment. So hepatitis B parallels HIV in that way. But we have a vaccine for B that we don't have for hepatitis C or HIV. So each of these viral infections is slightly different, but it also, in my opinion, is very much the same. Test everybody, you treat everybody, and of course, if you have a vaccine preventable disease, you implement vaccination for people who are triple panel negative. And one more simple comment about vaccine is you don't need to boost vaccine. You give them either a 2-dose of the 2-dose or 3-dose of the 3-dose regimen, and then you're done. You don't test them again. You don't check for antibodies. You don't need to boost those individuals. This is also making things very simple, and I feel very cost effective. Okay, we're scrolling through the MMWR. We're going to give you a quick tour. It's a very, very nice summary here. I really want to compliment the CDC team for putting this document together. In my opinion, for our wonderful current state of hepatitis B that we've entered this last week, this document is basically flawless. I read through it again last night preparing for this, and I think they did a fantastic job. Just highlighting here, up to 2.4 million with referencing our paper. And then the interpretation of these screening tests has been very confusing in the past. And they did a very good job of talking about what surface antigen, anti-HBs, and anti-HB core means. So this is a really good reference document that's really gotten rid of the fake news that was out there for 20 years that the core antibody test had a high false positive rate. I don't know why that was promulgated over 2 decades. The information on core antibody was released to and by the FDA in 2001 to 2002 when Roche and Abbott developed their 2nd generation core antibody tests. And it was clear that the false positive rate is 1 in 500 people. And at that low level, you see core antibody, they have cccDNA, and you take the next appropriate steps in those individuals. We have here about the box 1, universal hepatitis B screening. This is 18 years and above. There's a pediatric discussion. I think that's still ongoing. The triple panel is discussed, screening pregnant persons, and risk-based testing, which you want to do in a subtle, non-stigmatizing way to carry testing forward in the future. But if they've been vaccinated and fully vaccinated, you don't need to get an antibody test. You just make sure they've had 2 or 3 doses of the appropriate vaccine. And then those individuals are thereby protected. And there's no reason to check for hepatitis B in a fully vaccinated person who had a negative Hep B panel before they were vaccinated. These vaccines are phenomenally effective. And remember, they're a B cell vaccine and a T cell vaccine. So if you don't have antibody measurable, they got the vaccine, they still have T cell and B cell recognition, even though the antibody may not be present. So that's a super important concept. Move quickly through the chronic Hep B. There's just a lot of data here on outcomes. A really nice table here, not just about the test and the interpretation, but there's an action here. And of course, they did a very good job about resolved infection, but it's not resolved, it's just resolved in the blood. There's still infection in the liver, but here it talks about counsel about hepatitis B infection reactivation risk. So super nice table that you can use. typical serologic course. One thing I want to mention on this is when you're screening, some of the labs will automatically go to an IgM, anti-hepatitis B core, which is a nearly worthless test unless you're sitting with a patient in a setting where it looks like an acute liver injury that's taking place. And then you need an IgM. I've worked with LabCorp and Quest to fix their panels. So the chronic panel comes up first, not the acute panel. And I don't have to constantly be reordering tests on people who come back with an hepatitis A IgM and hepatitis B core IgM test, which is just doesn't help me. It doesn't help me decide about exposure or vaccine or immunity. Really, really important. So I think they did a really good job on with those. There's a nice issue about the systematic review methods that it took to get to this universal screening. So there's really, really good homework here that you can read through also. And then a review of the evidence summary. They had key questions that are on here, which we've already covered in some detail. They did talk about the harms of screening. There's harms of doing any test theoretically, and their harms are quite low. They discuss in review articles about, the pain of, drawing blood, the anxiety, potential costs, interpersonal problems that might relate to either even thinking about getting tested or you're in the process of being tested, and about learning infection. They did a very good job here about evaluating stigma, time, fear, reluctance, to disclose high risk behavior. I'm not going to really call it illegal risk behaviors because I don't think all these are illegal. They're just risky. But the CDC and this MMWR have done a very good job about discussing the issues of stigma. So I think this is an important step forward. We're really moving into a new world. This was modeled to be cost effective. They talk about the 2021 economic analysis that was here. Adults up to age 69 years of age, even at a low prevalence of 0.24%, this is still cost saving. So if you have a serious or fatal disease of any type, that 0.2% threshold becomes cost effective as long as the cost of your tests are reasonable. A package test for the triple test from Quest or LabCorp at a commercial rate is in the $60 to $90 range, and the wholesale rate's around $21 or $6 or $7 per test. And we've gotten that in some of our nonprofits. So there's a summary of findings here that really go through this. I think this box about rationale for universal Hep B screening is very important. This morbidity and mortality, it's an infectious disease, it's a stigmatizing disease, it has extrahepatic manifestations, it's linked to cancers other than liver cancer, including lymphoma. And then I mentioned infectious disease. This is horizontal infections as well as mother to child transmission. And when you reduce viral load, you decrease infectivity. This is standard across almost every type of infection, whether it's TB, virus, another bacterial infection. These are all issues that are important. It says management of chronic hepatitis B might prevent transmission to others. Well, what is management? Well, you put people on treatment and their viral load goes down, your risk of transmission is lessened. I think that's quite clear from a number of different settings, including mother to child transmission. And cost effectiveness is re-emphasized here. And this issue about reactivation, they did a good job about core antibody. And of course, identify people who can benefit from vaccine, and that back relates to the ACIP recommendations. You want to check everybody for hepatitis A to determine if they need need vaccine for immunity. You're going to check for hepatitis C to link them to hepatitis C care. They're hepatitis C RNA positive. They really deferred on the Delta inside this document. I think that's going to have to circulate back to AASLD to make a recommendation like EASL to test all surface antigen positive patients for Delta antibody. There is a little bit of reluctance to roll that out today because the second of the two largest major labs in the United States does not have Delta testing. That's LabCorp. LabCorp has been super responsive this last year to get Delta testing available, and I'm hoping they'll be available at LabCorp by June. So this whole issue about STDs and checking partners, checking household members, checking offspring, children. And that's what we do at our FQHC in San Diego, at La Maestra. So we really have a really good tracking system. And interestingly, most of the people who come into our clinic all their family is in the clinic as well. So we can pull their charts on our EMR, see if they've been tested, send a message to their provider through our EMR and to say, please check these. Well, one person I saw this week, I think it was from Sudan, had 7 family members that were being taken care of at our clinic that we'll be able to track down. I talk about HIV infections, different types of risk behavior are all detailed here. So this is really, really a wonderful document. Now, they went back to these prevalence to all these different countries. And yes, I personally have been in 73 countries. I'm looking at this list and see which ones I've missed. But we can't remember all these things. That's why we're just saying test everybody. And this is good for, I would say epidemiologic information, but it's not going to guide necessarily who you decide to test. Really good rationale. Here they talk about liver enzymes. Good news, they didn't use the word LFTs for AST and ALT, so I was super happy about that. These are liver enzymes. These are not liver function tests. And people with elevated liver tests, hepatitis B testing, of course, is part of what I call the magic 6 tests. It takes 6 minutes and it's less than $60 to work up people with elevated liver tests. And hepatitis B is part of that. Quite a bit more detail here about testing. So they, kind of each layer, they dig down a little bit further and further. They've got algorithms about action that are taking place. They've got risk behavior lists that are here, medical evaluation in general. CBC is really nice. It'd be nice if they put CBC with platelet count, because platelet count is one of our fastest and quickest ways to help stage disease. In the 5-line guideline, you'll see the 5th line is stage your patient for liver disease, what level of fibrosis they have. That can be done through the platelet count, through APRI score, FIB4, elastography, ultrasound, and know who, if your patient has hepatitis B, that they need to be linked to surveillance. You're going to counsel people who have hepatitis B not to drink alcohol. We don't have a safe level of alcohol in these individuals. And of course, changing behavior is very important. This document is extremely thorough, and all the way up to the point where they're talking about elastography, APRI, FibroSure, which I don't use, but FIB4 is a prominent issue on here also. There's other comments about vaccination and of course, future directions, which is really nice. So I think, Catherine, I've hit my time limit here. I've tried to move through this quickly. All these resources are available for people to share, educate, discuss, and thanks for giving me this time this morning to meet with everybody from Huntington Beach Liver Connect meeting. And it's free online. If you just go online and type in liverconnect.org, you can watch the next 4 days. We have a big session on B and Delta Saturday afternoon and Sunday morning that Ira Jacobson and I are chairing. So have a great rest of your day, and I'm ready for a Q&A, Catherine, if that's where you want to go.
Yeah, that sounds great. It looks like we had some questions come in the chat box. The first from Dr. Rutland asking, how often should you test your patient with active hepatitis B for hepatitis Delta? Should one screening be sufficient?
The answer in general is once is sufficient. But if you have an individual who was negative for Delta, active IV drug use, active other risk behavior, and they have a bump or a change in their enzymes or function, then you should recheck for Delta. So that's on an as needed basis. One time is sufficient for your foundation.
Great, thank you. Second question comes from Dr. Nicole Spector. She asks, frequently having isolated positive antibody core results, can you share the panel that you use from LabCorp? And she also just notes that it's really tough getting patients in for follow-up labs.
Great question. So LabCorp and Quest have what they call a chronic Hep B panel, not an acute panel. And they put the acute panel in the background. So the panel that every patient gets is surface antigen, total core antibody, and surface antibody. That's the 3, and that's what you should look for. And if somehow your EMR routes you to an acute panel, deviate, find the chronic panel, because that IgM test is just worthless, in my opinion, unless you have a clinical scenario of acute liver injury.
Thank you. Next question. What are your current thoughts regarding mutant isolates and potential false negatives of hepatitis B surface antigen? How prevalent is this an issue?
False negative for surface antigen is extremely rare. It does help define this tiny subset of occult hepatitis B infections. That can be a false negative, typically because there's surface antigen mutations that take place. Roche and Abbott, the two biggest ones, Diasorin's in that mix. They've done incredible work trying to find all those mutants and making sure we're detecting those mutants. So the false negative rate has dropped from less than 1 in 1,000 to, I'm going to say, about 1 in 10,000. But they do exist. I'm working on one by email with one of my colleagues from Iowa and Robert Perillo, trying to get a person worked up that we think is false negative, but we'll figure it out.
Thank you. Can you comment on any persons who were vaccinated in the early 90s or 2000s? Does the immunity wear off?
The people after vaccine have lifetime immunity, and I'm going to say lifetime right now. We have data out into the 30-year range, 3 decades. That's from Africa and from Alaska. So the antibody wanes through what's just called senescence, but the B cell memory and T cell memory will persist lifelong. And that's why we're saying don't boost, don't test, but just make sure you have documentation they got the 3 doses of vaccine. And they say, well, I got a couple, I'm not sure. Then in that case, you could give them an additional dose of either the VBI or the Heplissav-B and say, okay, now you've completed, and we have in writing that, again, don't check a titer after that, just give them 1 dose of those 2 vaccines. I'm mentioning those 2 vaccines because they both have a, I call it an immune adjuvant environment for that vaccine to get a much better immune response. These are T cell vaccines. We have a T cell response that's measurable. We don't have a test to measure it, but there's been lots of research by, I call viral immunologists, to document that T cell protection.
Thank you. The next question, how do you explain those slow to mount sufficient immunity? Is there something that we should look for? And then I'll follow up with that and dealing with non-responders as well to kind of go along with that question.
Well, since we are not checking surface antibody after vaccine, we have no idea if people are slow or fast or intermediate responders. So I'm going to say, don't test, don't think, just vaccinate, say goodbye, provided you've got that triple panel negative. It's going to make your nighttime anxiety much less, and we're going to be able to talk about testing and treating everybody.
Great. For chronic hepatitis B, does high viremia, i.e. high viral load with normal liver enzymes, predict the future of liver injury?
Yeah, the answer is yes from multiple perspectives. First off, high HBV DNA is associated with many, many more integrations. So that integrant frequency and location is what helps predict future risk of liver cancer. We lay on top of that ALT and liver inflammation, fibrosis, that amplifies cancer risk. But if you're checking ALT twice a year, you're basically getting ALTs that might reflect 12 hours of time twice a year, and we have 365 days. So ALT importance is much less now, and that's why we're just saying DNA positive treat. But to look at stage of disease, ALT gives you a risk potential, but stage people with FIB4, FibroScan or Velicure, one of the other elastography. Look at the spleen size, look at portal vein diameter. Get a full ultrasound on every Hep B patient. First baseline, you can then decide later on frequency of that. But that first ultrasound should give you a lot of information. I posted yesterday on my website what's called a synoptic on how ultrasounds should be read by a radiologist. You can download that synoptic, hand it to your radiologist and say, I'm tired of these 2-line ultrasounds, normal, normal, and they don't really give any description. You want a quality reading on those ultrasounds.
Great, thank you. Want to see if there are any other questions from the audience. Oh, here we have one just came in. Would you give some examples in your experience for reasons of any false positive for hepatitis B surface antigen, cases where everything is negative, but surface antigen stays positive?
I'm working through another scenario like that right now. And the classic one is somebody got Hep B vaccine and you're testing them within a few days of getting the vaccine. And believe it or not, there's enough antigen circulating in the blood, or B test goes down to 0.05 IUs. It's like a tiny amount of B, super sensitive, super useful. So the false positive surface antigen could also be a post-vaccine in people on dialysis. That surface antigen hangs out for a couple of weeks after vaccination. There's also, every test has a possible false positive rate due to some other protein in the body that's similar to surface antigen, although I can't name one of those, but that's a 1 in 10,000 events. All these cases are occult hepatitis B, and core antibody is not perfect. I mentioned the false positive rate is super low. False negative rate, we don't fully understand, but there have been case reports published. But this is a very rare setting. Somebody comes up with a couple surface antigens positive, core is negative, S is negative, E antigen and E antibody are negative. I would wait 12 weeks and test them again. If it's still surface antigen positive, call your best local hepatologist, such as Dr. Fenkel, to help you.
Great, thank you. Any other questions, be sure to raise your hand or put them in the chat box. And speaking of Dr. Finkel, I want to bring you into the conversation about the screening guidelines. And maybe if you could talk about your perspective on the guidelines, and then if you have any thoughts on, ways in which we can think about future directions towards Philadelphia and implementing those guidelines, both locally and then more regionally.
Sure, thank you, Catherine. And thanks, Dr. Gish, for that great presentation. Obviously, we were excited on our end about the guidelines. Simplifying who should be screened has been a huge effort, and I'm pretty good at geography, but like Dr. Gish, it's hard to remember every country all the time, where patients with their families might be from that put them at risk. On our end, what we've started to do is trying to engage like a group of interested providers at our institution in improving sort of as a quality initiative to implement the guidelines more effectively. From a whole system perspective, we're limited until these are approved or endorsed by the USPSTF. They won't implement them into our EMR formally. But I did build in the HBV screen panel for LabCorp Quest in our local lab to make it a one-click order, integrated into our system, which is helpful. And we're going to sort of sprinkle some quality improvement around the institution to figure out where these patients may be and where the best place to find them may be. Our maternal fetal medicine and OBGYN colleagues do a great job screening for hepatitis B already on pregnant women. I think we've got opportunities in many parts of even in our own GI division. I'm sure there are patients that don't have a triple screen already on their chart. A lot of them have been screened for B, but not just with the surface antigen. So.
Great, thank you. I appreciate, even though we don't have the USPSTF recommendation there, like you guys still working to incorporate things where you can until that recommendation is there. And I think that's a really important strategy that others maybe on the call could also work to incorporate within their institutions or clinics. Great, thank you. I know we have Katie Nguyen and Myra Rutland also on the line with us today. Wanted to see if you guys have any feedback or thoughts on how those guidelines might impact your practice. I know you guys are both part of our expert advisory group for the Philadelphia region.
Hey, everybody. It's really exciting. I think it takes a lot on the ground level to make the change happen. So I feel like I have more talking power now when I talk to my leadership about hepatitis B screening. I know I'm using that when we're planning for May for hepatitis month, using that as a tool to hopefully mark charts and start some type of reminder system for screening. But I think it's like everything else that we are supposed to be screening for in primary care. It can be repetitious, but I think repetition is good, and hopefully it will increase our numbers of screening. Thanks.
Awesome. Thank you. Appreciate that.
Thank you, Dr. Friedland, and congratulations. And hello,
Thank you.
everyone. Yeah, I think that this is a awesome opportunity and timing was perfect. I try to keep in front of my colleagues the job of screening for Hep B and impressing upon them the importance of it and the prevalence of it, because maybe the prevalence of a positive core is lower nationwide, but I would say for the numbers that I'm seeing in our patient population, it's much higher. I'm in Philadelphia. West Philadelphia is where our headquarters are, and we have people from all around the world. I would say our positive core rate is upwards of 50%, which is impressive. And that's just touching the iceberg. Those are just the few that I see when I go through charts as a lone ranger. So timing was perfect. I shared the guidelines that you sent to us via email. I'm going to definitely share this paper. And just recently, I think there was an article that came up, CNN talked about the importance of screening for hepatitis B and the endeavor with the Biden administration putting $11 million behind eradicating Hep B and C. So just using those tools to back up what I've been saying, I feel like I'm standing on the tarmac waving the flag, and this is now just giving some credence to what I've tried to share. Thank you.
Thank you. Thank you all for your comments and your leadership. And also want to highlight that point, Dr. Rutland, that you mentioned about the core positives and that being something that we're also seeing at the community level. Really a lot, especially in the African immigrant community. We've been testing for the triple panel for since August, and we've been really surprised by the volume of isolated core and also core positives. So I think there's a lot to be explored further in that space, and also making sure that we're testing for that triple panel is really important. Dr. Gish, feel free, I see your hands up.
So this issue about core being positive is a true test that people have Hep B exposure. It tells you how much risk events occur in a given community. 50–60% of people have had some type of intimate blood exposure to B and could easily have C, HIV, other exposures as part of that scenario. So core antibody to me is you've had blood exposure, you've had a risk event, and this is very, very frequent.
Mm-hmm. Important point. Thank you. Great. Any other comments from the audience about the guidelines or questions that they might have about them?